All right, so disaster management and bioterrorism. So are you ready for this type of emergency? I think we all know that, especially in this day and age, anything can happen at any time. You know, there's 9/11, there's these examples on here in other countries. Even the at the state fair, back in 2011, that, you know, the stage collapse that, you know, was considered a multi-casualty incident. So it can happen anywhere, anytime, even if you are not a first responder, so to speak. We could, you know, us as nurses can still be there as a resource to help in these disaster events. And then when we go on to talk about pandemics as well, we're living it, aren't we? So how would you handle it? So disasters can occur and cause widespread destruction and distress and catastrophe. You know, there's all different types. And our natural disasters, which are floods, earthquakes, and then man-made, which can be industrial explosions or acts of terror. And the type and level of response needed depends on the type and the severity. So a mass casualty event or incident, is any situation in which the number of casualties exceeds the number of resources. So in the hospital setting, that definitely, I mean, it could even be, you know, a car accident with 2 vehicles that each have like 8 people in it or something, you know, 2 vans. I mean, that's 16 people, 16 traumas that could be potentially flooding the hospital, and that would cause the number of casualties to exceed the number of resources. So we have to have disaster planning. So special consideration, so mental health of both the responders and the victims, planning for special needs populations, such as our elderly, children, and persons with disabilities, and persons incarcerated. And the surge capacities in hospitals and clinics also need to be taken into consideration. Agencies involved with disasters. We have our federal agencies, Department of Health and Human Services, Department of Justice and Defense, Homeland Security, FEMA, our Federal Emergency Management Agency. And then we have our state and local, American Red Cross, Office of Emergency Management, that's responsible for providing interagency coordination during an emergency. So our EOP, our Emergency Operations Plan, regardless of where you work, knowing your facility's emergency plan is important. Many facilities have scenarios, sometimes, you know, either annually or even biannually or something, to just try and help prepare to give an idea of what it would be like in the event of a disaster of some sort. And the essential components of this plan then are, you know, an activation of the response, internal and external communication, plan for coordinated patient care, security plans, identification of external resources, and a plan for people management and traffic flow. So it's just a priority of all involved. I think it was last fall. Was it last fall? Pretty sure last fall, or maybe even like the spring before. Parkview did a really big disaster scenario. It involved hundreds of people and employees. It was a really cool event that really kind of opened up their eyes to see like where their holes were in figuring out like if this were to happen, what they would do. Did anybody work at Parkview in the last few years that got to participate in that at all? Because we got to have, we had a lot of our students that got to participate in it that semester. But then there was also, you know, obviously it was also a lot of their own staff that was involved as well. And then Lutheran did one also on a much smaller scale. But it was really neat. And if you ever do get the opportunity to be involved in something like that, I highly encourage you to do so, because it's just neat to see. Not only I mean, we've never experienced anything like that on that type of scale in our area, but, you know, who's to say it couldn't happen? And it was really eye-opening to see they learned a lot from that situation, as far as like, okay, this is what we did wrong, this is what we could do better in a real event. And those type of things are just really important to kind of work out those kinks as best as you can to try and prepare for the worst. So the incident command system, it's a federally mandated command structure that coordinates personnel, facilities, equipment, and communication in any emergency situation. So you have the commander, the unified commander, and then all the people underneath: planning, logistics, operations, and finance. The hospital incident command system, it's a modification of the incident command system that's used by hospitals. And this also includes a commander, a safety officer, public information officer, liaison, operations chief, logistics chief, planning chief, and finance chief. So a lot of the same titles, but just modified for the hospital system. And each team member communicates back directly to the incident commander. So the essential components of the plan: data management, deactivation response, post-incident response, a plan for practice drills. So again, that's an example of what we did at Parkview. Anticipated resources, mass casualty incident planning, and education for all of the above, because of course that's important. We need to know what we're doing in these type of events. Key health system challenges. So the leadership, of course, if you don't have a clear and organized and responsible leader, that can cause mass chaos as well. Pre-hospital care, patient transport and distribution, hospital care, community and media relations. We know that media plays a big role in trying to, either make or breaking people's panic. Communication, both internal and external. So with pre-hospital care, you need to manage the availability of the EMS personnel, assess the situation in the area, protect on-scene personnel. So you always want to protect, if you are that first responder, you definitely want to protect yourself and assess the area and make sure you're not putting yourself in any danger. Stage and triaging patients, providing appropriate transportation, and managing fatalities. So body bags, religious beliefs, preserving, identifying, and storing human remains as well. So assessing the situation, as I already mentioned, keep yourself safe. Don't become a victim yourself. Expect the unexpected. Look all around. If it was an attack, expect a second attack. Case in point, 9/11. So assessing the situation, that's SEPIA: structural damage, exposure risk, perpetrators, items out of place, and abilities. Do you have the right training? So of course, this picture has a lot of potential hazards and is a disaster event. I don't know where that was at in particular, but so triage then. So triage is going to be our main focus on this disaster area, and how we triage patients essentially in the field in these disaster type situations. Triage is the sorting of patients to determine the priority of healthcare needs and the proper site of treatment. In non-disaster situations, we assign the highest priority and allocate the most resources to the most critically ill, right? But in disaster situations with large number of casualties, decisions are based on their likelihood of survival and the consumption of resources. So you want, in disaster situations, it's now, instead of 5 people helping this one person, it's if they meet criteria of having a high chance of death, then you just have to move on, because you want to do the most good for the most amount of people in a disaster situation. So we have our different categories. We have red, yellow, green, and black. So our red is our immediate, yellow is delayed, green is our minimal. Those would be like our walking wounded, and then black is our deceased or our expected to die. So that's the color coding system that's used. And when you're triaging, it's the START triage method. So simple triage and rapid treatment. And in identifying their color system, we use the RPM, which is respirations, perfusion, and mental status. So this is key, and it's a very rapid assessment. Should be less than 15-30 seconds per patient in order to color code them. And you always start where you stand. You don't go to the back of the room because a mom is screaming with her newborn in her arms. You start where you stand, because then it just doesn't have the flow. You need to keep the flow so that way you're not missing anybody. And it's just very important that you start where you stand and begin your triage from there. So there is a video. So I'm going to do the second one because it breaks it down. It's the same video, but just it shows like the event first and just what they're doing, and then the second one, though, breaks it down and explains it. So we're going to watch this one because it explains it really.
Now let's return to the bus accident and learn how to use the START techniques.
I need everybody who can stand up and walk to do so. You can stand up and walk outside here, over to the curb.
It is important to clear the scene of as many minor injuries as you can. Direct victims who can walk to a specific destination nearby and tell them to stay there. By asking the walking wounded to leave, the rescuer has just triaged 9 victims into the minor injury category in a matter of seconds.
How are you two doing? You look okay. I need you guys to stick around to help me, so just wait right here, okay?
Non-injured bystanders can be used as a resource to help provide basic first aid to those who are injured. This is part of the rapid treatment that takes place during initial triage. What victim gets your attention first? The unconscious child? The man covered in blood? The hysterical bus driver? Because you have no way of knowing at a glance who and where the most critically injured victims are, you start where you stand. Patient assessment begins as soon as the walking wounded have been directed away from the scene. The START assessment is simple and easy to learn. It only has 3 steps. RPM. Respiration, perfusion, mental status. RPM. When you're facing a multi-casualty incident and you're all revved up, just remember RPM. Now we'll learn how to use RPM to assess each patient in about 30 seconds. Respiration is the first assessment because it is the most critical function. If the patient is not breathing because of an obstructed airway, attempt to clear the airway. Depending on the type of obstruction, either reposition the patient's head or remove any debris that may be lodged in the throat. While repositioning an injured patient's head may be contrary to what you've learned about cervical stabilization, Dr. Greg Super explains how to handle a patient who's unconscious and not breathing.
If we do nothing, he's a certain field death. If we open his airway, we may aggravate an existing cervical spine fracture. We chose to make that intervention. If we open his airway, he makes attempts to breathe, and we can keep that airway open, he may have a chance to survive. If we leave the airway closed, he has no chance.
If respiration cannot be reestablished with these simple measures, don't waste time attempting CPR.
The first rescuer's basic instinct might be to begin CPR on the first one he encounters. That would be a mistake. These people die. If the first rescuer goes to CPR on the first victim he finds in full arrest, he will not be available to help those who still have a chance at living.
Non-breathing patients are considered non-salvageable and are categorized deceased. Move to the next patient.
Okay, need help over here. Need your help support his head. Okay, just like this. Need you to help keep his airway open. Just like that, okay? Great. Don't let the airway close.
If the patient begins breathing after the airway has been cleared, categorize immediate and move to the next patient.
Rolling.
To assess respiration on a patient who is breathing, observe the frequency of respirations. Patients who are breathing at a rate of more than 30 respirations per minute are categorized immediate and no further assessment is done. Move on to the next patient.
Oh, sorry.
Although you won't take time to actually count respirations, you can become skilled in visual assessment by watching others simulate rapid breathing. With practice, you will be able to easily differentiate between a person who is breathing faster than 30 respirations per minute and one who is breathing at a normal rate. If a patient is breathing slower than 30 respirations per minute, proceed to the next assessment, perfusion. Here's how the respiration assessment looks on the START flowchart. If the patient is not breathing, reposition the airway. If breathing does not resume, the patient is non-salvageable and is categorized deceased. If breathing resumes after you clear the airway, categorize the patient immediate. Patients who are breathing at a rate of more than 30 respirations per minute are categorized immediate and no further assessment is done. If the patient's respiration is slower than 30 respirations per minute, proceed to the second assessment, perfusion. In a multi-casualty setting, the capillary refill test is the fastest and most effective way to check perfusion or circulation. To do this, press down on the patient's nail bed and release the pressure. The skin underneath the nail should return to normal color within 2 seconds if perfusion is adequate. If it takes longer than 2 seconds, categorize immediate and move to the next patient. The radial pulse can also indicate perfusion status. If you cannot feel a pulse, the systolic blood pressure has probably fallen below 80. The patient's legs should be elevated to improve blood flow to the heart, lungs, and brain, and the patient categorized immediate.
Put as much pressure you can on there. I need you to stop her bleeding, okay?
In situations where a patient has severe external bleeding, direct the patient or a bystander to apply pressure to the wound. If the patient has adequate perfusion, proceed to the third assessment to check mental status. On the START flowchart, the perfusion assessment looks like this. Check capillary refill by pressing down on the patient's nail bed. If color does not return within 2 seconds, categorize the patient immediate. Elevate the legs and control bleeding if necessary. If the patient has adequate perfusion, the nail bed capillaries will refill within 2 seconds and you will proceed to the third and final assessment, mental status.
What's your name?
Brain injury accounts for half of the deaths in disasters. Patients with altered mental status are categorized immediate. You may have already observed the patient's mental status during the first 2 assessments. If the patient is unable to respond to simple questions or commands, categorize immediate.
My leg over here, my leg. Oh God, I think it's broken. I think
relax,
it's broken.
just relax. Okay,
Get me
you're
out of
breathing
here.
fine. You're breathing fine.
Get me out of here. Please, my leg really hurts. It really
Okay, you've got a
hurts.
good pulse. You've got a good strong pulse. What's your name?
Jan.
Okay, Jan. What day is it?
Friday.
Friday. Good.
Please,
Okay.
it hurts. Oh God.
More firemen are coming. Okay, we'll get you out of here as soon as possible.
Hurry.
All right, I've got help coming.
If the patient can follow simple commands, categorize delayed and move to the next patient. Here's the mental status assessment on the START flowchart. If the patient fails to respond to simple questions or commands, categorize immediate. If the patient can follow commands, categorize delayed and move to the next patient. The delayed category does not mean the patient is not injured and does not need treatment. It means the patient isn't at high risk of early death. As you have seen, every patient is triaged and categorized depending on the need for medical attention at the time of assessment. Immediate patients need to leave the scene as soon as transportation arrives. For patients awaiting transport, a second, more thorough field assessment will be done by qualified personnel. They will update the patient's condition and provide further treatment. You have just seen how quickly and efficiently you can use START triage to rapidly categorize and treat patients. When you're one of the first rescuers at a multi-casualty incident, your START training ensures your efforts do the most good for the most people. In this video, you have learned how to direct the walking wounded away from the scene to reduce...
Okay, so that is just a really good video that really breaks it down simply and easily as far as the RPM method. So the biggest takeaway with your RPM when you're triaging is if they can walk to you, they're green. You just automatically give them a green. They may have some wounds or some injuries, but if they're green, they got up and walked to you, so their perfusion's good and their mentation's good, that you understood that they were coming. They might, you don't necessarily look at their respirations specifically, because if they're really struggling to breathe, they're not going to get up and walk to you either. So if they're walking to you, they're green. And then as you go through, then you do the start where you stand and each patient. So if you come to the first patient and the respirations are less than 30, you move on to perfusion. If they have cap refill that's less than 2 seconds or a good radial pulse, then you move on to mentation. And then if their mentation, they follow commands, and they're not don't seem to have any mentation issues, then they're just automatically a yellow because they didn't fall into that RPM red category. They're automatically yellow. They didn't come and walk to you, but they have some type of injury that's preventing them from getting up to you or whatever the case may be. So they would be a yellow. Now, as far as mentation goes, you obviously aren't going to ask them things like their name and date of birth, because I mean, you might ask them their name just so they can tell you, but you don't know their name. And you certainly don't know their date of birth and those type of identifying factors that we normally use in the hospital setting. You're going to just simply see if they can follow commands and they're alert and at least somewhat know what's going on. You might have an elderly patient who normally has dementia, and you may not know that, but if they're following simple commands, then they would still be classified as yellow and not red. So that's where the mentation comes into play. You just want to make sure they're following commands and are at least alert. So if you go down the RPM category and you come up to someone whose respirations are clearly greater than 30, they're tachypnic and you know, whatever other injuries they may have, but automatically you don't even have to go through the perfusion and mentation because they're already a red just because of their respirations. So you just, it's fast as you can go. Like as soon as they fall under one category, you stop there, tag them and move on. So those are the big things: respirations greater than 30, perfusion greater than 2 seconds or no radial pulse that would indicate poor perfusion, and not following commands. All those would classify someone as a red tag. And then as the video had mentioned, if they're not breathing, you reposition the airway. If they're still not breathing after repositioning the airway, they're black. So you don't start CPR, you don't give rescue breath. Now pediatrics is a little bit different, but we don't talk about pediatrics in this class. So you do give some rescue breaths for peds, but otherwise, if they don't start spontaneously breathing after repositioning the airway, they are black. Other greater than 70% burns are usually categories as black also, because their chance of survival is very, very poor. So those are the main things. Now, if they do start spontaneously breathing after repositioning the airway, again, you just label them red and move on. You don't have to go through respiration, or don't have to actually measure the respirations, because you already know there's a problem because they weren't breathing when you came to them. And also, people always ask, well, what is the minimum respirations? In this situation, there's no minimum. It's just repositioning the airway, and if they start spontaneously breathing, they're automatically red, or the greater than 30. There's no less than, it's just greater than 30. So yeah, and you always want to control the bleeding.
What was the percentage for the burns?
70%. And then with,
I had a quick question.
Yeah.
So on respirations, if you are assessing them and they're breathing, you haven't had to move them or reposition them, as long as they're breathing and everything else, like you stop there and you go to red, if they have altered mental status and all that?
If you come up to them and they're breathing, and you didn't have to reposition, and they're not greater than 30, you know, they're not like super, you know, you can tell that they don't have some tachypnea, then you go to perfusion. If they don't have, if their cap refill is greater than 2 seconds, or you can't palpate a radial pulse, you know, you could they can still be breathing. Obviously, if they're breathing, you know they have a pulse. But if you can't palpate a radial pulse, then that means that their perfusion is super, super low, that they can't get those distal pulses.
So then you can stop there and put them as red?
Right. And then you don't have to go to mentation. If you walk up, I mean, you know, some of them you can almost skip even over perfusion. If you walk up to them and they're breathing, you can see that they're breathing, but they're completely unconscious, then you automatically know they're red because their mental status is less than, or they're not going to follow commands. They're just, something's going on. They have some type of head injury likely that caused them to be unconscious.
Okay.
So yeah, anytime they fall into any of those, the RPM categories, they're automatically red and you move on. Okay. All right, and also with perfusion, controlling bleeding. If you see that they have you always want to, usually they'll put a tourniquet on if they have like a open leg fracture or something that they're profusely bleeding from. You control bleeding and go through the RPM then. So you always want to control bleeding. Okay, so like I said, I'm pretty sure I've got something that we'll do next week to kind of solidify some of this stuff. But this will be the main part that I want you guys to concentrate on as far as for the test stuff with the whole disaster thing, is the triage. Okay, all right, so then we have our PPE. We know PPE is important to shield us from chemical, physical, biological, radiological hazards that may exist when caring for contaminated patients. And there are the different levels of protection. Level A would be our highest level of protection, which is a self-contained breathing apparatus, vapor-tight chemical resistant suit, gloves, and boots. And then it goes all the way down to level D, which is just our basic uniform. So there is a handout that has like the CDC guidelines for donning and doffing our PPE. So refresh yourself with that. But the biggest thing, the most important thing, it's important, donning is important, of course, but at least you're starting out, you're not going to contaminate yourself, but doffing is really important. So that way you're not contaminating yourself in any way. So one easy way to remember doffing is it's alphabetical. It's gloves, goggles, gown, mask. And we always want to remove the mask from the back. We never want to like remove it from the front because if you haven't done hand hygiene, you've just taken everything off, you don't want to potentially contaminate yourself. So you always remove from the back. And terrorism. So terrorism, sorry guys, I just gotta make sure. I have someone that's supposed to be coming to my house today for an appraisal, so I'm making sure they're not coming early because they're supposed to be here at 12. Okay, so terrorism is our weapon. We can have lots of different weapons of terror: explosives, biological, chemical, and nuclear. Explosives, especially blast injuries, can be very life-threatening. Blast injuries is just where the movement that goes through the air can travel through the lungs and cause damage to the lung just from the movement, which can cause like hemorrhage and the lungs to tear and that sort of thing. So it can be very life-threatening. And then of course you can have tympanic rupture, abdominal and head injuries as well. So we're going to talk about a few of these. So our biological agents may be delivered or spread in a number of ways. And due to modes of travel, spread of infection can occur areas of thousands of miles away. Healthcare providers, we need to be aware of potential signs of biological weapon dissemination. Signs and symptoms are similar to those of common disease processes. So it can be a little scary not knowing that it could potentially be a biological agent. Like the case that I think of is like the anthrax thing, when that was going around, like putting it in like letters and stuff like that for people, that would be an example of a biological agent. So isolation practices depend on the infecting agent. We always use standard precautions regardless. Some agents do require transmission-based precautions, and terminal disinfection and disposal of waste is dependent upon the infecting agent. So it's going to depend on what it was that was used, will determine how we dispose of it. Chemical weapons then are substances that quickly cause injury and or death and can cause panic and social disruption. So these are nerve agents, blood agents, vesicants, and pulmonary agents. And the agents vary in volatility, which is the way that they're dispersed, persistence, toxicity, and period of latency. Chemical agents are usually heavier than air. So if a chemical agent were to be dispersed, it's actually better to stand. Sometimes your first thought is to like get low to the ground or something like that, but actually you should stand because they do fall because they're heavier than air. Those particles are heavier than air, so you should stay standing. And then limitation of exposure is essential with evacuation and decontamination as soon as possible and as close to the scene of the incident as possible. So that's true with any type of agent used, because you don't want to bring the agent, to the hospital or closer to anywhere outside of where it's already been affected. So still keeping the patients, the victims, closest to the area that it occurred to decontaminate them there to prevent the spread elsewhere. So usually you set up a decontamination area somewhere near where it occurred. Nerve agents then are examples of that are sarin and somain organophosphates. Nerve agents are easily dispersed and they produce symptoms within seconds. So they can be very life-threatening very, very quickly. They inhibit cholinesterase, which causes cholinergic symptoms to progress to loss of consciousness, seizures. They can have copious amounts of secretions, apnea, and even death. Treatment is supportive care, and then atropine, benzodiazepine, and pralidoxime are the antidote for these nerve agents. So those need to be given as soon as possible to try and reverse it. And you want to decontaminate with copious amounts of soap and water or saline for at least 20 minutes. You're going to blot, not wipe off. And if you have any plastic equipment that you are using, the sarin gas will be absorbed in it. So that needs to be taken into consideration as well if you're using anything plastic. Then you have your vesicants, which is lewisite, which is a type of arsenic compound. And then your sulfur mustard, nitrogen mustard, phosgene causes blistering and burning, and respiratory effects can be serious and cause death. Decontamination also with soap and water. Don't scrub or use hypochlorite solutions because it can cause the burning and the blistering to be worse. Eye exposure requires copious irrigation, and treatment for lewisite exposure, the reversal agent for that is dimercaprol IV or topically. That dimercaprol is a chelating agent that removes the heavy metals from the blood. And then you have radiation exposure. So we know that radiation can be a chemical weapon, but also our cancer patients too. I mean, they get radiation, and we need to be careful with our exposure for some of those patients that are getting like internal radiation. So that would be a more realistic and not a chemical warfare type of problem, but we still need to be aware of it. Radiation exposure can occur due to nuclear weapon, nuclear reactor incidents, or exposure to radioactive samples. Exposure to radiation is affected by the time, distance, and shielding. And then the types of radiation exposure, external radiation, so all or part of the body is exposed to radiation. Decontamination is not necessary and it's not a medical emergency. And then contamination, the exposure to radioactive gases, liquids, or solids require immediate medical management to prevent incorporation, which incorporation is the uptake of those radioactive materials into the body. With radiation decontamination, again, triaging outside the hospital. You're not going to, bring them to the hospital. You're going to cover the floor, use strict isolation precautions to prevent tracking of the contaminants. Air ducts and vents are sealed. Waste is double bagged and labeled radiation waste. So that goes too for, our patients who are receiving that internal radiation, their like waste, like their urine, if they have a Foley or something like that, their products need to be properly, their waste products need to be properly disposed of and can't just go into the regular system as well. Staff protection, water resistant gowns, 2 pairs of gloves, caps, goggles, masks, and booties. And then dosimetry devices that measure the level of radiation you're receiving. So that alerts you to when you've been having too high of exposure that you need to leave the area. So those dosimetry devices are really important as well. So patients are surveyed for radiation and directed to the decontamination area. Decontaminate each patient, again, outside of the ED. They should have a shower, and then those waters, tarps, towels, soaps, gowns, all patient belongings must be collected and contained. Patients are surveyed and reshowered as necessary. Showering should be performed to not contaminate clean areas with runoff from the showering. And then you'll get biological samples, so nasal and throat swabs, blood specimens. And then internal contamination requires additional treatment. So they might need that catharsis, gastric lavage with those chelating agents as well. Radiation injuries. So radiation injuries, acute radiation syndrome, the dose of radiation determines if acute radiation syndrome will develop or not. All body systems are affected by this, and the presenting signs and symptoms determine the predicted survival. So probable survivors have no initial symptoms or only minimal symptoms. Possible survivors present with nausea and vomiting that persists for 24 to 48 hours. And then improbable survivors are acutely ill with nausea, vomiting, diarrhea, and shock. And neurological symptoms suggest lethal doses, and their survival time may be variable. All right. Any questions on that before we move on to our pandemics? Okay, so our pandemics. We're all a little too familiar with some of this. All right, so pandemics. The definition is it's a global outbreak of a disease. Could be used as biological terrorism attack as well. So the 4 pandemics in the 20th century, and now we have our lovely COVID-19 for 2020. But the Spanish flu, which is what they were originally predicting, you know, the deaths to be more like the Spanish flu, but now we have well exceeded that. So the Spanish flu was 500,000 deaths worldwide, but now it's like up to over a million. I know it's over a million worldwide now with COVID. But influenza pandemics are more likely to be catastrophic, last longer, deplete available healthcare workforce, and reduce the supply of medical equipment. So we have the swine flu, which was the H1N1, avian flu, H5N1, and then SARS, which COVID is SARS-CoV-2, I believe. So the swine flu or H1N1, it's not really new anymore. I need to update some of these. But it was a strain of flu that consists of genetic materials from swine, avian, and human influenza viruses. Signs and symptoms similar to the seasonal flu. Additionally, vomiting and diarrhea occur and usually last about a week. It affects the respiratory system. It's highly contagious, and it's caused by contact with an infected person or by touching something such as toy, tissue that the infected person has touched. And it is airborne and contact precautions. There is no vaccination for it. Now, with a lot of these, especially like the SARS, and we know COVID's this way too, typically is really droplet, but with many of them, they can easily become airborne because if it's aerolized, or which is why like our COVID patients we have on airborne precautions because, you know, if they're on the ventilator or they're receiving those aerosol treatments and stuff, it's easily aerolized. Is that right? Is that right? Aerosolized, aerolized? I don't know the correct word, but it can become airborne easily with certain treatments. So in the public, wearing masks still can help prevent you from, you know, with droplet precautions, wearing a mask and doing proper hand hygiene and everything. But then in the healthcare setting, when we see a lot more of these treatments that can cause the virus to become airborne. So take these at face value with, because the biggest thing I want you to know with these pandemics is their method of transmission and what type of isolation they should be in. So just take it for what it is and try not to get overly think about it. I'm just telling you real life, they're typically more so droplet, but can become airborne.
I have a question.
Yeah.
But I just wanted to clarify. So the slide says that there is a vaccination, but you said that there was no vaccination.
Did I say that?
Yeah.
I didn't mean that.
Okay.
There is a vaccination. Sorry.
Okay. Yep, that's okay.
Thank you for correcting me. Okay, so then we have H5N1. This was the avian flu. Affect birds, does not usually affect humans. However, there have been human cases that have been reported, and the majority of cases are attributed to direct contact with the poultry, but in rare instances, it does suggest that human-to-human transmission. Symptoms are often like influenza A, B, and C. In diagnosis, there's the H5N1 flu test that detects a specific protein, which indicates the presence of that H5N1 from the nasal or throat swabs. Also a vaccine and also airborne. Now it says airborne in contact. If you're on airborne, you know, that's a higher level of contact, so you're going to be in contact if they're airborne. So symptoms and treatment of influenza. The acute onset of fever, muscle aches, you know, we know many of these symptoms: headache, fatigue, weakness, anorexia, sore throat, cough, rhinorrhea, and interventions: rest, fluids, and supportive therapy with antipyretics or antitussives, and antiviral medications. So that oseltamivir, which is our Tamiflu, and zanamivir, which is Relenza. So our antivirals are used commonly during outbreaks and depends on the current strain of influenza. Common side effects of the antivirals: headache, dizziness, fatigue, nausea, vomiting. And then more specific side effects for those ones, I can't say, the VIRS. We have the insomnia, diarrhea, abdominal pain, and cough. And then with the zanamivir, ear, nose, throat infections, diarrhea, nasal symptoms, cough, sinusitis, and bronchitis. You want to administer them within 2 days of onset of symptoms. So that's important that they get those as soon as possible. And it doesn't prevent the transmission of influenza to others, but it will help alleviate symptoms so they're not as sick as long. Plan for prevention and containment. Early recognition of new cases and implementation of community and personal quarantine and social distancing behaviors to reduce the exposure of the virus. Well, that sounds familiar, doesn't it? And when a cluster of cases is discovered in an area, the vaccine is made available for immunizations. Trying. And antivirals. They're widely distributed, but again, as I mentioned, it won't prevent the disease, but will reduce severity and mortality. And again, infected people should be in strict isolation, and all non-essential public activities stopped, including school, and people stay home and use stockpiled food for at least 2 weeks or longer. So any influenza pandemic is a disaster, and containing it requires the cooperation of all people. Any pandemic is a disaster, not just influenza. We know that. So SARS. SARS then, it was first identified in China in 2002, different strain than what we have now. Syndrome begins with fever, overall feelings of discomfort, body aches, and mild respiratory symptoms. And then after 2 to 7 days, a client may develop a dry cough and dyspnea. Chest x-ray shows a pattern similar to pneumonia. An infection is spread by close person-to-person contact with infected materials. Again, airborne, but close person-to-person contact, and it's also with heavier particles that make it more so droplet, but we place people on airborne precautions because of the potential for it to be airborne. And in your text, I believe it doesn't say SARS in IGI, it actually, I think it's called MERS, Middle Eastern Respiratory Syndrome. So if that confuses you, it's somewhat, it's in the same section that it says MERS in there. And there's also a really good table in IGI in chapter 23 that's got the different pandemics in there, and just states the precautions and just other things in there. So it's just a really good table in IGI. So you should definitely look at that, refer to that when you're looking at your reading. And so SARS, the diagnosis is made by the manifestations of the use of the rapid SARS tests. And it's no known effective treatment, but standard antibiotics and antivirals cannot kill the virus or prevent its replication, but interventions are supportive. So oxygen, bronchodilators, intubation, mechanical ventilation. Antibiotics are used for bacterial pneumonia. Oh, I spelled that wrong. That may occur with SARS. So we know that people diagnosed with SARS, with COVID, often develop severe pneumonia and can have sepsis. And antibiotics are definitely used. The antiviral that has been more effective with COVID is, what is it? I forgot it yesterday too. Remdesivir is the antiviral that we've been using with COVID. And there's all sorts of other treatment options that they've been experimenting with as well. All right, so then we have Ebola. So Ebola is a virus that's spread through direct contact through broken skin or mucous membranes with blood or body fluids, including but not limited to urine, saliva, feces, vomit of a person who is sick with Ebola. So, and other objects like needles and syringes that have been contaminated with the virus and infected animals. So it's not spread through the air or by water or in general food. However, in Africa, Ebola may be spread as a result of handling bushmeat, which is that wild animals, in contact with infected bats. And it lives on the surface only for a few hours. Signs and symptoms: fever, headache, muscle pain, weakness, diarrhea, vomiting, abdominal pain, and unexpected hemorrhage. So that's the big thing with Ebola, was that just hemorrhage and the severe vomiting and diarrhea. When they were worried about the Ebola outbreak, I don't know how many years ago that was now. I think a few cases first started, in like Florida or something. And we prepared, I mean, we looked like that level A, other than it being like an actual breathing apparatus. Like we literally had to wear like pants, like the booties and pants and special gowns, and put like a hood on, like everything. It is only droplet precautions, but because of the excessive amount of bodily fluids that and hemorrhaging that goes along with Ebola, you need to kind of take extra precautions with those droplet precautions. Incubation period: symptoms may appear anywhere from 2 to 21 days after exposure, but the average is 8 to 10 days. And recovery from Ebola depends on the patient's immune response, as with anything. And people who recover from Ebola infection develop antibodies that last for about 10 years. So the diagnosis: detected in blood only after the onset of symptoms, usually a fever. It's detectable by that real-time RT-PCR from 3 to 10 days after symptoms. And then treatment: providing IV fluids and balancing electrolytes because of that severe dehydration that they can go into from excessive nausea or excessive vomiting and diarrhea and blood loss. In maintaining oxygen status and blood pressure, and treating other infections if they occur. Infection control, as I already mentioned, droplet. Everyone should wear gloves, gown, eye protection, and face mask, but as I already said, additional PPE might be required in certain situations because of those excessive body fluids. So then the Black Plague. The Black Plague then, the plague from, I don't know, medieval times, whenever that was, is this, but it does still exist. It's from the bacteria Yersinia pestis, and it's usually spread by fleas. Can also catch it from infected animals or people. Most cases are in Africa, but also India and Peru. US sees about 7 cases a year, mostly in rural or remote areas in southwestern states like Arizona, Colorado, New Mexico, and California. And there's 3 different types. You have your bubonic, septicemic, and pneumonic. So all types cause severe sickness with fever, chills, and headaches. The incubation period is 2 to 8 days. The bubonic plague is the most common type, which causes those buboes, or like those boils, which are swollen and painful lymph nodes under the arms and the neck or in the groin. And then septicemic is more dangerous than the bubonic because the bacteria has moved into the blood. And then there's bleeding under the skin from the mouth, nose, or bottom, blackened skin, especially on the nose, fingers, and toes, and then belly pain, diarrhea, vomiting, and shock. Then the pneumonic is the rarest form of the disease, but it's the most deadly without treatment because now the bacteria are in the lungs. And it's very contagious because the plague can spread through the air when a person coughs. Cough sometimes with blood, trouble breathing, and nausea and vomiting. The prevention: there's no vaccine for the plague in the US, so if you have a chance of contact with the plague germs, take steps to protect yourself. Diagnosis: the testing for that bacteria Yersinia pestis in the blood or body fluids. In treatment, without treatment, it's deadly. But antibiotics are a big part of treatment, and they should be on droplet precautions. Smallpox, it's caused by the variola virus then, and it can be taken from varicella. So smallpox is not chickenpox, it's very different. It's the variola virus, not the varicella. Incubation time is 10 to 17 days, and it is highly contagious. Symptoms can cause severe malaise, headache, high fever, that papular rash 2 to 3 days later that becomes painful and pustular. Vaccine does not give lifelong immunity, and the last vaccine was given in 1980. So there is a vaccine still available out there. Smallpox does still exist. It's just people are not routinely vaccinated for it anymore since it had been practically eradicated, but it is not. So if such a situation would arise, they would start vaccinating people again. And it is airborne precautions because it can be spread through the air and is very, very highly contagious. All right.